It's really a great honor and privilege to be here today, not just because it's such a magnificent setting and an important annual event, but because what the Staglins do, what IMRO does, what One Mind is beginning to do, what the advocacy for mental illness research has been doing is not just appreciated and important for researchers like myself in the field of psychiatric medicine and mental health care, but it's our salvation, because what is happening with regard to the economic situation in funding biomedical research, particularly in the area of brain disorders that affect mental function and behavior, is, as my Jewish grandmother would say, is a shander. It's an embarrassment, because we have a contraction in NIH funding. Historically, this area has been underfunded, and with the Great Recession and the cost containment efforts on healthcare spending, when we're poised to make the greatest progress, we're pulling the rug out from under ourselves. So this effort that the Staglins with colleagues are leading is really our salvation for those of us that have dedicated our lives to this field. I'd like to talk today about, as Rob Malenka said, where we've come in the field of psychiatric medicine and mental health care in thinking about not just how we can produce the new discoveries that'll affect the cures for mental illness, which is obviously the ultimate goal, but how we can do something right now or in the foreseeable future that's going to change the lives of people who develop and suffer from mental illnesses. So I want to begin with a little anecdote. In 1976, the Nobel Prize for Medicine was awarded to Dr. Carlton Gajdusek, and many of us know Dr. Gajdusek as a real kind of curmudgeonly character, but he made the discovery, he got the prize for making the discovery of what causes a spongiform encephalopathy, a disease like mad cow disease at the time, and which was called Kuru. And ultimately, through the work of another Nobel Prize winner, Stanley Prusiner, was found to be caused by prions, a microorganism that's of the smallest and the most sort of stealthy form that exists in the animal kingdom. And I was seated at a dinner a number of years ago with Dr. Gajdusek, and the conversation was about research and how the progress and the best roads to pursue for the next discoveries. And he said, but you know something? The advances in healthcare are due as much to the application of existing knowledge as opposed to the discovery of new knowledge. We're all breathlessly waiting for the breakthrough that'll find the cure, identify the gene, that'll lead to the elimination of illnesses that we concern ourselves with, like has occurred with polio, like has occurred with smallpox. But in the meantime, there is much that can be done if we muster the political and social will to apply existing knowledge that can radically transform the way healthcare is provided and the lives and outcomes of people who develop mental illnesses. This is very important, not just from a quality of life and a scientific and medical standpoint, from an economic standpoint. The World Bank and the WHO have conducted studies on the global burden of the disease over the last 2 decades. And what they find is that if you look at the cost measured in disability life years, that although later in life, cardiovascular disease and cancer are substantial burdens in terms of morbidity, mortality, and expense. During the peak years when an individual forms his identity, begins to define their professional or career direction, and his peak productivity, it's the mental disorders that are the most burdensome. And then later in life, it's what are called the neurological disorders, but this is really a false dichotomy because these are both brain disorders, both groups of brain disorders. It is this that is becoming, because of the increasing longevity, the recognition of dementias, and the occurrence of cerebral vascular disease, which are the most burdensome. So the areas that affect the brain, the diseases affect the brain, are the most costly to our society in economic terms. Just looking at it in terms of dollars in the US, the top three, historically, cardiovascular disease was the biggest killer and the biggest cost. Now it's not because of the progress that's been made. And currently, you see cancer, cardiovascular, and mental disorders as the three leading disease areas in terms of actual costs for direct care of these disorders. Yet the amount that we spend on mental disorders is a fraction of those on heart and oncologic disorders. Now, this is a famous photograph taken from in the latter part of the 19th century, which depicts what are called asylum inmates, but that basically reflected the nature of healthcare, of mental health care, up until really the latter part of the 20th century. And that was, there was nothing that could be done because we had no treatments with proven efficacy other than to humanely care for people custodially by putting them in institutions which are like little cities to live in. Today, we have a whole spectrum of treatments, both pharmacologic and psychosocial and service-related, but those are only incompletely applied, and they don't work as we would like to, and many people fall through the cracks. The whole process of deinstitutionalization, which downsized the number of people kept in mental institutions, led to many of these individuals becoming homeless or not being cared for in a way that was even equivalent to how it was when they were maintained in institutions. Where we are heading with the arrival of neuroscience, genomics, pharmacology, and the concept of personalized or precision medicine is really being able to identify premorbidly or in the very early stages of an illness before it syndromally expresses this phenotype, individuals who are at risk and intervening to preempt the onset of the illness or at least prevent its damaging effects from occurring. So this is the future, and this is the paradigm that we now embrace. And it's a paradigm which has been applied in many different organ systems and disease areas, and it's a paradigm that is appropriate to apply for brain disorders, including those that affect mental function and behavior, i.e. mental illnesses. It is a paradigm that's timely for implementation now. It's not waiting for new knowledge to be discovered. It can happen now. It's a matter of social and political will to enable it to happen. Now, the trajectory of major mental illnesses, and by that I'm referring to schizophrenia, the prototype mental illness, schizoaffective disorder, and the psychotic mood disorders, which include bipolar disorder and severe major recurrent depression with psychotic features, follows a trajectory generally depicted here. We assume that the diathesis, the basis from which these conditions arise, has something to do with genetics, so it actually begins at gestation and birth, but these disorders rarely occur prepubertally. It's almost always after puberty that they manifest themselves, very rare to occur prepubertally. But when they crystallize into their definable forms that DSM or ICD enables us to diagnose, somebody is said to have their first break, their first psychotic episode, and that usually dates the formal onset of the illness, even though the illness has been brewing and even expressing itself for some time earlier than that. Now, we now know that treatment at these early stages are quite effective. They suppress symptoms, they can prevent recurrence. However, practice guidelines and practice patterns don't generally sustain treatment after someone has recovered from a first episode indefinitely. Generally, people stop medicine, treatment isn't provided in a full-court press in an aggressive way, and what happens is people experience multiple recurrences in the form of relapses, and you can think of these as little brain attacks that result in the phenomenon of decline or clinical deterioration. And many brain diseases follow this pattern of degeneration, deterioration. Parkinson's disease, Alzheimer's disease, Huntington's disease, cerebral vascular disease. In those diseases, generally there's an inexorable decline that occurs to death or complete disability. In the case of the mental illnesses that I mentioned, this reaches a plateau where people don't decline any further other than in the context of aging, but they remain permanently symptomatic and disabled. And they arrive at this end stage that we used to see in terms of people when they were custodially maintained in asylums. So this is the trajectory. Historically, treatment was gauged at suppressing symptoms, but not necessarily preventing the deterioration from occurring. Through the advent of non-invasive neuroimaging techniques like magnetic resonance imaging, it's been determined that as this process occurs, as an individual goes into the prodrummle phase, into the first episode and subsequent, there is a process where their brains shrink by small amounts, but by measurable amounts. And what is lost is principally areas of gray matter reflecting synaptic connections in specific parts of the brain that mediate the functions that are involved in the symptoms that the disease expresses: perception, cognition, mood regulation. Work that's been done by a number of the scientists here, Ty Cannon's group at UCLA, a number of individuals have demonstrated this convincingly. So this becomes the substrate that has been linked to the clinical deterioration that is the hallmark of these illnesses and results in the persistent morbidity and disability associated with them. What we think is actually responsible at the cellular and molecular level for this gray matter volume shrinkage is that the illness begins to be expressed in symptom form when synapses fail to regulate the release and reuptake and postsynaptic stimulation of neurochemicals. And if this isn't suppressed by treatment, isn't stabilized, it leads to an elimination of these synapses and a pruning of this dendritic arbor reflected here. This is actually a photomicrograph of postmortem brain tissue that was done in the laboratory of David Lewis at the University of Pittsburgh. And here you see this dendritic spine with these little bumps, which are, these are dendrites with these little spines that are bumps that form connections for synapses from other cells. And in individuals with schizophrenia, you see the density is reduced. And so it's thought that this occurs as a consequence of this iterative process in the illness and leads to the gray matter volume reduction. So we've come to think of these illnesses as having their origins genetically in the way the brain forms, in the vulnerabilities that the brain has to functional and maturational pressures that are placed on it, that makes it ripe for dysfunction, expressing the symptoms of the illness, but also it has a progressive and, on a limited basis, a degenerative component also. So if it was only genetic, then preventing it would require a different therapeutic approach. If it has a progressive and degenerative component, then that's something we might be able to that might be actionable now. And this is the question of, can we prevent the onset or change the course? So after close to 50 years of research with current psychopharmacologic agents, which really were first introduced after World War II and in the 1950s, what we can now say absolutely positively, no question about it, is that the antipsychotic drugs, as a cornerstone of treatment, can suppress psychotic symptoms and prevent their recurrence. But they don't eliminate psychotic symptoms in everybody, and they don't eliminate them necessarily fully. Some people partially respond. And they don't eliminate the negative symptoms. And they don't eliminate the cognitive symptoms. In fact, they don't even touch those. There's no efficacy virtually on those symptoms. But what we do think is that by suppressing these and preventing their recurrence, they can prevent this progression, which is huge. So as a consequence, our thinking has evolved to understanding the illness as having a premorbid phase, where the genes and the early environmental factors are influencing the development of the brain. Very little of the phenotype is expressed then. After puberty, in this adolescence, early adult stage, those synapses, under pressure from the stresses that occur in adulthood, in adolescence, pressures of performing in school, getting ready for college, perhaps entering the military, getting married, recreational drug use, all-night raves. Those synapses begin to dysregulate in trafficking the neurochemicals that are critical, and as a result, symptoms begin to be expressed. At that time, those can be suppressed, but if they're not, that deterioration sets in, and then you lose synapses, dendritic spines, gray matter. And that leads to the slippery slope of degeneration, persistent symptoms, that chronic persistent stage of the illness. So the focus has been get there early and prevent this. And initially, getting there early was here, when you could get to the first episode when somebody had been having these symptoms for some period of time before they finally came to treatment. But through the work of people like Ty Cannon and other individuals around the world who have really adopted this early detection intervention approach, began to shift to here. But the question is, well, before I get to the question, let me just give you a little example by illustration of what the difference, I think, can mean by getting there in time effectively and not. So these are two brief movie clips, hope the sound projects okay, that I think illustrate the dichotomy between what good treatment applied in time can do and lead to, and when, as more often tragically is the case, it's not in time and it's not optimal. So the first is somebody I think you've seen, Ellen Sachs, who's at Pat Levitt's institution. She's an endowed professor in the law school, and she won a MacArthur Genius Award, and she just published a book called The Center Cannot Hold about her experience with schizophrenia. And on the left is another habitué of Los Angeles, Nathaniel Ayers, who was the subject of a book by journalist Stephen Lopez that got made into a movie, The Soloist. And the difference between these two is simply the quality of the treatment. Ellen came from an upper-middle-class family in Miami. She went to Vanderbilt. Then she was a Rhodes Scholar, and she had her first episode when she was in Oxford. She came back, graduated from Yale Law School. She's had the best of treatment, supportive family, and look where she is. And unfortunately, Nathaniel Ayers didn't. Now, bipolar disorder follows a similar trajectory with slightly different genetic diathesis and phenotypic expression. But it has similarly onset in adolescence or young adulthood, has a high heritability, has a recurrent course in virtually all people, becomes more frequent in recurrent episodes over time, can develop persistent symptoms and disability, and is highly disruptive to life, family, and environment, leading to hospitalizations, substance abuse, suicide, and the potential for violence. It has particular challenges for treatment because it's a complex disorder. We're going to hear from Colleen, one of our next speakers, about the work that she's doing relating to circadian rhythm genes. And this is relevant because there's a periodicity in this illness in that it manifests itself in different phases, an excited manic phase or a depressed dysthymic phase. And the whole illness is really centered around the instability in mood regulation and the oscillation between these extremes. So treatments need to be phase-specific. It can also occur in mixed forms. In addition, with all of these psychotic disorders, particularly bipolar disorder, there are problems in terms of adherence or compliance with treatment. There is frequently a lack of understanding of the nature of the illness, an unwillingness to accept that an individual has this illness, narcissistic injury, also the euphoria of mania is something people don't want to be deprived of, and therefore people are often very reluctant to continue in treatment. But we have treatments. We have pharmacologic treatments in the form of lithium, a whole array of mood stabilizer, anticonvulsants. We use antipsychotic medications, antidepressants, and psychosocial treatments, including family therapy, interpersonal therapy, social rhythm therapies, life management, are highly effective if they're adequately and fully implemented. Similarly, imaging and postmortem studies have shown that, although not to the same degree as the shrinkage or atrophy occurs in schizophrenia, there is similarly a loss of gray matter in the form of dendritic spines, neuropil, synapses that occurs in bipolar disorder in its chronic forms. And through the work of individuals like Husseini Manji, it's been shown that at least lithium is able to have a slight regenerative effect in terms of being able to re-stimulate the growth of gray matter. The problem, I submit, though, is that we have treatments that work, at least in terms of our understanding of how best to use them, informed by the more recent neuroscience. But we don't apply them. People are symptomatic for far too long before they ever come to diagnosis and treatment. The average for an individual with schizophrenia is a year. The average for somebody with bipolar disorder is longer, and the average for somebody for depression is 5 years. When they receive treatment, treatment is given, the person gets better, they hope it's the end of it, and if the doctor or the healthcare providers don't explain to them, no, this is a lifelong thing, you're not finished, you can remain in remission, but you have to remain in treatment, then they leave and they're susceptible to relapse, and the vast majority of people do. So it's not encouraged, and people left to their own devices stop treatment, drop out. They find out the hard way. So we've come to think of the illnesses in a way that's like Humpty Dumpty. Humpty Dumpty sat on a wall. Humpty Dumpty had a great fall. All the king's men and all the king's horses couldn't put him back together. Can treatment restore individuals after they've experienced this chronic exposure to the illness? And the answer is not yet, not fully. Rehabilitation can work. Cognitive remediation is great, but it doesn't restore people to how they were before they got ill. God willing, in the pharmaceutical industry, getting re-involved, we'll have regenerative medicine, and that is a critical scientific approach that needs to be embraced, not just for neurological disorders, but for mental disorders as well. Until then, though, the adage from Ben Franklin applies, and we can make it work. How do we know that? Well, we've seen it before. In 1995, Dwight Eisenhower, when he was president, had a heart attack. After World War II, the leading cause of death in the United States has been heart disease. When he had a heart attack, the treatment was put him in the hospital, let him get better, put him on rest, let him go, stop smoking, watch your weight, and hope you don't have another one. In the 50 years since then, the rate of mortality from heart disease has been cut by 60%. And the whole field's been revolutionized. In part, it's better medicines, statins, surgical techniques, but it's really just applying public health approaches. So now, you don't wait till somebody has a heart attack. You can identify them when they begin to have early symptoms, and you can do tests to assess whether they're at risk, whether they have blockage, whether they have shortness of breath, whether they have symptoms. Even before they develop symptoms, you can take steps to prevent the risk based on family history, based on certain gene profiling, based on tests that look at plasma biomarkers or stress exercise testing. And you can modify lifestyle to minimize risk. And this has worked. We haven't, even though we can, applied this in the same way in mental illness. We know somebody can have a family history, but pre-symptomatically we don't screen people for markers. We're beginning to develop an approach in terms of the prodrome, but it's still at a fairly early stage. And basically we wait for people to get sick, and we treat them, but we don't treat them maximally. We don't put on a full court press at that first episode of illness, which is the best time you'll ever have to interdict a mental illness. And we can. The rationale is that you'll minimize disruption in life, you'll facilitate early treatment, you can prevent progression, and you can help the family accommodate to what the illness threatens them with and what they need to do in order to avoid that. So how can we do that? Well, at the very least, we can identify people here at the first break and make sure that we throw the kitchen sink at the illness. What does that mean? That means treating with multiple forms of treatment: medication, psychoeducation, case management, a kind of supportive psychotherapy, supported employment, supported education, if they're going back to college, going back to the job. And to sustain that, not for 6 months, 9 months, a year, but for an extended period of time and potentially indefinitely. People like Ty Cannon and colleagues have said, okay, well, why wait till people get sick? Let's find them before they get sick. Let's look at the prodromal phase. Great idea. That's the idea. And the work that they've done has shown that it actually is viable. If you use certain behavioral or symptomatic predictors, and you then follow individuals who have these high-risk signs for several years, you find that 35% of them develop a diagnosable psychotic disorder. Problem is that 65% of them don't. Now, this idea of identifying people early and potentially intervening then is not entirely new, even though it didn't really get pursued seriously until relatively recently. An eminent psychiatrist in the 1930s said, with regard to schizophrenia, we want to know how to split clearly between the people who are having troubles and living and those who are at grave risk of psychosis. So when you're a teenager or a young adult, your behavior varies markedly because of the fact that you're sort of dealing with a lot of transitional issues. How do you distinguish that from people who are actually on their way to developing a psychotic disorder? That's the issue. So here's a guy in a bar who says, what do you mean your guess is as good as mine? My guess is a hell of a lot better than yours, your guess. So we shouldn't be guessing about this. We can't, sort of roll the dice because it means labeling somebody, it means giving them a medication, it means incurring side effects. So what we need is a valid biomarker, a valid diagnostic test. So for a test to be effective, it has to be able to determine who is going to develop the illness and who is not. So you need a test which shows a positive finding and individuals that go on to develop the illness, the true positives. And you have a test where the result is negative in people who don't develop the illness, true negatives. The problem is when you have false negatives, the test is negative on people who do develop the illness, or is positive on people who don't develop the illness. And the current criteria work, but they don't work good enough for us to put this into practice in the clinic and get Medicaid, Medicare, insurance companies to pay for it. The best biomarker that we have currently are structural measures like we showed that measure brain volume. And these can be applied. However, if you think about the way illness works, when somebody has a shrinkage or an atrophy of the brain, that's after the damage has been done. Cells go from being morphologically, structurally, and functionally normal to showing signs of dysfunction, becoming sick before they die. It happens with Parkinson's, it happens with Alzheimer's, and it happens in disorders like schizophrenia, bipolar disorder, and depression as well. So ideally, you'd like to be able to have something that could identify the illness there, a biomarker that works there. There's some that are in progress that show real promise. This is one, which is a PET technique, which looks at the synthesis, the trafficking, and the regulation of release of dopamine. And it uses a radiotracer called F-DOPA to measure dopamine concentration in the striatum of the brain. And what it finds is that individuals who have schizophrenia secrete 100%, 1 to 2 times as much dopamine into the synapse than do individuals that do not. The other technique, and this is what I'll show you just in terms of the only real data in my presentation, is work that we've been doing of late, inspired by the Prodrummle work that's been done, is to try and develop a functional imaging biomarker to predict who is going to develop full-blown psychotic disorders from people who look like they're at high risk in the prodrome. And to do this, we focused on this structure in the brain, the hippocampus, because in the postmortem literature, it's the structure of the brain that's most consistently and prominently affected. Hippocampus, and this is a slice through the hippocampus as if you sliced it like this, is actually a very complicated structure which has different cytoarchitectural regions with connections internally and also to different parts of the brain. And so we needed to develop a very high-resolution, spatial resolution technique that evaluated function that could distinguish between these subregions, because the idea was the illness doesn't start all over the brain all at once. Even in Alzheimer's, it doesn't. It migrates in a circuit or in a pattern. And so we wanted to find out, where does it actually begin? So to do that, we developed, and this is the work largely of a colleague, Scott Small, a functional imaging technique using MRI that measured blood flow and metabolism. And these are color maps which show the degree of blood flow and metabolism, and the cooler the color, the lower, the hotter the color, the greater. And here's a control subject. You see it's all greens and blue in their hippocampus. Here's individuals with first episode schizophrenia. You see this big red area, which is in the CA1 region. And these are prodrummle individuals who have this reddish area here in the subiculum in the CA1 region. And when we then followed these prodrummle individuals who had not yet been diagnosed for 2 years, in 2 years, you see the red, these are individuals that converted to a DSM psychotic disorder. They had higher levels of this metabolism, hypermetabolism, in the CA1 and subicular regions of the hippocampus. Candidate biomarker. When they were re-imaged, after they developed syndromal psychosis, here's the hippocampus and the prodrome. You see the mildly reddish area. And then when they converted, you see how it's hotter. Also, here's orbital frontal cortex. No increased metabolism here in the prodrome, but now it's increased. But not in the dorsolateral prefrontal cortex. So it's spatially specific. Turns out that the CA1 projects to the orbital medial frontal cortex. So we believe that this hypermetabolism gets propagated to the frontal cortex in this region as the illness progresses. Now, it's critical to be able to explore these things to understand how the cellular and molecular pathology develops and treatments can be applied to have animal models. So using this, we then tried to develop an animal model for this. And here's the data from the human studies. We have our hippocampus, we have our subregions, we have the hypermetabolism in the subiculum CA1 region. So we went to mice, and we used a standard kind of pharmacologic model for psychosis by injecting an NMDA antagonist called ketamine. And injecting mice with ketamine, we see that it also elevated their CBV, their metabolism, in these two regions. So it produced the biomarker in mice using this pharmacologic model. We then speculated, well, what is causing the hypermetabolism? And to determine this, we inserted a glutamate sensor, which measures the concentration of glutamate release in this region, and found that by injecting ketamine, we produced a spike in glutamate. So we then said, okay, so glutamate is driving this hypermetabolism. It produces the biomarker. It elevates glutamate. A therapeutic strategy, if that's really linked to the symptom expression, would be to suppress the increased release of glutamate. So we then took some compounds that are known to have an inhibitory effect on the release of glutamate. And we injected in the red ketamine. Instead of giving a medication, we gave just salt water, saline, and you see the spike. It occurs in the hypermetabolism on the imaging, and it occurs in terms of the glutamate concentration. Here's our control sample, which got no ketamine and got no treatment, and you see it doesn't spike, it just goes here. Now here, in blue and green, are groups of animals that got pre-treatment before the ketamine was administered with two agents, gabapentin, lamotrigine, that affect the release of glutamate and by inhibiting it. And you see what they did is they suppress it. Gabapentin seems to work better than lamotrigine, but they both suppress it. Here. Turns out that the Lilly drug, the mGluR23 agonist that just got killed by Lilly, works too. So go figure. But that, I think, means that it needs to be used as a prodromal treatment as opposed to a treatment after the full-blown syndrome has been developed. But this is the approach by which we can develop treatments to prevent the illness and not have to use antipsychotic drugs in the prodromal phase to treat individuals who are at risk for developing schizophrenia. So here's my take-home messages. Psychotic disorders derive from genetically mediated neurodevelopmental diatheses and are progressive. The symptoms are just expressed due to neurochemical dysregulation. That can be suppressed by treatment. But if not, there's the risk for deterioration and persistent morbidity from structural pathology which develops. So the goal has to be to prevent that. Medications can prevent this, and early detection and intervention is effective in preventing or limiting illness, but requires refinement of diagnostic methods and the identification of treatments like these glutamatergic compounds suggest, and then also reconfiguring our models of service delivery so we can get out and find people earlier. Now, what are the obstacles to this? Well, no, listen, if you have a problem that you don't know anything about, money's not going to help it. You've got to find people who are smart, you've got to educate them, and you say, you go figure this out. You go build an atom bomb, a Manhattan Project. Okay? We don't have to do that. You've got, Brandon introduced a dozen kids here who's got IQs of 200, who have more degrees and have been in school for longer than all of us put together, and are smart as can be. You know, we're getting the best and the brightest, but we're not giving them the tools that they need to figure this out. We're trying to fight this war, this battle, with one arm tied behind our back. Now, I just want to come back to this. Look, it shouldn't be a zero-sum game. Cancer is a bad disease. Heart disease is terrible. They all need approach. Historically, we've been underfunded, and the science has never been stronger. Neuroscience is poised. The brain is orders of magnitude more complex than the other organs. What's the heart? The heart is a pump. It's got 4 chambers and muscle and some tubes. The kidney's a filter. The brain is 100 billion cells, 3 trillion synapses. If you look at one part of the liver compared to another part of the liver, they all look the same. If you look at one part of the brain compared to another part of the brain, it looks totally different. It's vastly more complex. We should be spending much more on it. The thing is we now have the workforce that can do it. Psychiatry has other things, though, opposing it. It's not just the historical. We have stigma. And we have an organized anti-psychiatry movement. You don't have an organized anti-movement against any other disease area. And Scientology is, I mean, they're like mortal enemies because they're well-financed. Look at their website. We're competitors in the marketplace for. So I want to leave you with something. Most of you, or many of you, are probably too young to have seen this movie, but I remember when it came out in 1976, I loved it. And there's a little passage in it that I think makes me think is sort of appropriate for where we are. If you think about advocacy, and you think about what it can do, all you have to do is look at 2 recent examples, AIDS and autism. So AIDS is a new disease. When I was in training in the late 1970s, the first papers came out. We didn't know what it was, so we called it acquired immunodeficiency syndrome. And then Montagnier and Gallo discovered the virus. It was HIV, still a death sentence, an embarrassment, a stigma, no treatment. And then protease inhibitors, antiretroviral therapy, vaccines on the horizon. It's a new ballgame. Autism. Autism wasn't even described in the medical literature until 1947. It's existed for millennia. Where was it? It was hiding in plain sight. We just didn't notice it, or we called it something else. No treatments for it. No understanding whatsoever about the genetics, about the neurobiology. Now, it's a major public health problem. You can't go a day without seeing something on TV or hearing something about it. So these things can change.